My name is Miguel Regueiro. I'm professor of medicine at the University of Pittsburgh Medical Center and the medical director of the Inflammatory Bowel Disease Center. So I gave a talk yesterday on hot topics in inflammatory bowel disease, and to provide an overview, there were really four topics that I discussed. One is the use of biosimilars for the treatment of inflammatory bowel disease. The second is whether we can stop biologic therapy or immunomodulator therapy in patients in remission. The third was positioning biologics for the treatment of IBD. And then the fourth is new care models, specifically a patient-centered home for inflammatory bowel disease. And to briefly just touch on each of those, biosimilars in inflammatory bowel disease are really emerging from a cost perspective, and there will probably be two from the biologic domain in inflammatory bowel disease in the next couple years. One will be similar to adalimumab, and one will be similar to infliximab. So I think cost will make sense. The question is, are they interchangeable, and where do they position within that domain? The research in biosimilars for inflammatory bowel disease has been somewhat limited in the sense that there are no clinical controlled studies, and probably the FDA will not mandate that. So as a physician community, we're going to need to decide where we position ourselves in biosimilars as they hit the market. And my sense is, just as a bottom line, if a patient's not been on a biologic, it's probably okay to start a biosimilar. If they are on a biologic, we probably won't want to switch to a biosimilar based on the immunogenicity. So today I'll be chairing a session that looks at the safety of immunomodulators and biologics in patients who have cancer or had cancer in the past. So Jean-Fred Colombel will be part of the panel discussion, Jim Lewis will be part of the panel discussion, and Tom Ullman will be part of the panel discussion. And I will be moderating a case-based discussion on the safety of medicines in the setting of cancer and IBD. Yeah, so I think the take-home message is this. One is that thiopurines possibly have a link more highly with lymphoma, and we see this potentially in our young male patients and elderly patients as well. Nonetheless, I still use thiopurines in those settings, but I think we need to have some caution around that. The second is that skin cancers, basal cell cancers, squamous cell cancers have been linked to thiopurines, and we need to be careful with that. The third is that biologics, specifically anti-TNFs alone, are probably safe, and actually safer than I think we thought 10 years ago when they first came out. And the new agents, the integrin agents, specifically vedolizumab, seems to be very safe because it's gut selective. So patients who may have many cancers are safety concerns. It may be that preferentially we're using vedolizumab in those patient populations. So I think it's applicable to other specialties in the sense that immunosuppression for other immune-mediated disease, rheumatoid arthritis, psoriasis, now in the domain of oncology and hematology, where we're seeing a crossover of diseases and different immunosuppression. And certainly we're working closer with our oncology colleagues, our dermatology colleagues, as we see these malignancies and trying to position these treatments with the help of some of these other specialists. So I think what I'm hoping to bring back to the practice from this meeting are a few things. One, what are the new treatments that are on the horizon? So for example, tofacitinib and ustekinumab are probably two that will come out in the next couple years. The second is, how are we going to use biosimilars as they emerge? And the third is this concept of new models of care. How are we addressing the Healthcare Reform Act in terms of new models of care? So those are probably the three top.